after. So if you don't like something, let us know. So now I'm going to introduce our first speaker, Sandra Billinger. Dr. Billinger is a professor at the University of Kansas and the director of the Research in Exercise and Cardiovascular Health Laboratory, and she's the Neurovascular Division Director of the Alzheimer's Disease Center at the University of Kansas. She is a fellow of the American Heart Association, which means her professional accomplishments, volunteer leadership, and service are recognized by that eminent organization of cardiovascular and stroke professionals. She has practiced for over 10 years in geriatric, neurologic, and cardiopulmonary physical therapy. Dr. Billinger has received continuous grant funding from internal and external funding sources, including the NIH, the American Heart Association, and the Cardiovascular and Pulmonary Section Research Grant of the American Physical Therapy Association. And these grants have focused on cardiovascular health, exercise-related interventions, and how physical activity impacts stroke recovery. So we're really honored and thrilled to have her with us. And without further ado, I'm going to let her share her screen and proceed with her talk.
Thank you so much, Liz. I appreciate the opportunity to speak today, and thank you for that wonderful introduction. It was very thoughtful. I just want to make sure, Liz, just if you can nod your head if you can see my screen and everything looks good here. Okay, wonderful. So it is an honor to be here, and I'm so excited to talk about something that I've been passionate about for many, many years. I always like to highlight because I like to connect with people. I've already tweeted out Liz's screen earlier, but you can follow me at Sandy_ReachLab on Twitter if you're if you'd like. As she mentioned, I'm still funded by the NIH, and I do have a patent pending, so I have to disclose those things. Here are the objectives. You can go through those for this course. And I always like to start my talks with this quote of the day, because I always felt that this is such a powerful statement. And it's one of those things that we don't always think about exercise as a medicine, but it does require, and we'll talk about how it requires prescription and kind of thoughtful assessment, and then also how do we prescribe it, and especially for our patients, as Liz mentioned, that giving individuals control over what they can do. And I feel that in my physical therapy practice, a lot of times patients either didn't know what to do, they had a lot of questions. So again, if we can give them that information, they can, take that and hopefully incorporate that into their life. But I always highlight this, that, the benefits of exercise are quite vast, and that if we could take all the benefits of exercise and package them into this pill, it would be the single most widely prescribed and beneficial medicine in the nation. And I always like this little, the exercise pill, take it with you wherever you go, take it out on a jog, and then go to a gym, because again, exercise is so important. If you haven't seen this, this was highlighted in the New York Times. It's a little wellness blog that is done, but the actual published paper here in Cell is right here if you're interested in looking this up. But the authors were interested in what a single session of exercise does. And again, we know that it upregulates and downregulates a lot of molecules, but we just really didn't know how much or what that impact was. And so if you're interested, this is a really great article that talks about all the things that are upregulated and downregulated in the blood. This was healthy individuals. It was a small sample, but it certainly was a good start to highlight all the changes that exercise does. So when I talk about exercise, we talk about that it's more effective than drug, but that's only for certain drugs. And the outcomes of this meta-analysis was mortality. So again, it's not looking at some of the things we may be interested in, such as blood pressure control. But again, looking at this, we found that exercise is more effective for treatment after stroke than antiplatelets and anticoagulants. But when I give this lecture to both healthcare professionals and to our community audiences, I never suggest that anyone should ever stop taking their medications. Always talk with their physician or a healthcare provider on how they can incorporate exercise with the medications that they're taking, because exercise can be an alternative also alongside drug therapy. And so here's the image for stroke. You can see they looked at a lot of different patient populations, but specifically for this talk, I'm highlighting stroke. We see that exercise has a very positive or beneficial effect. And again, they didn't look at, hypertension wasn't in here, but you can see that exercise had a better effect on mortality. So when we talk about cardiorespiratory fitness post-stroke, I think it's important to understand first, when we look at fitness in our patient populations, very seldom do we see max, VO2 max, because this is really the maximum amount that we can go has been established on healthy people. And that's meeting certain criteria for our age predicted heart rate max. It's looking at reaching certain respiratory exchange ratios, heart rates, and that's not always easy for individuals who have physical limitations or disability. So we usually talk about cardiorespiratory fitness as VO2 peak. And so Marilyn McKay-Lyons, colleague and friend of mine, in 2002 published that in this acute stage, and again in Canada, this is within those first 30 days, their VO2 peak was 60% lower than age and sex matched peers. And so what I really wanted to do was look at all the data that we had here at KU Med Center and really look at that against the criteria in the American College of Sports Medicine's guidelines, the exercise testing and prescription book. And what we found that VO2 peak was below the first percentile. And we published this information in 2012. And just to give you an idea, because we had a vast majority of people across a larger age span here. And so F is for females, M is males, lower extremity Fugel-Meyer scores are listed here. So you can see the variability. If there's no standard deviation, we only had one person in each of these categories. So again, it's not, we wish we had in the hundreds and thousands of individuals, but we actually only had a small number of people. But you can see that when we look at the normative data, and again, they have above average, excellent, average, below average, and then they have these percentile ranks. And so for most of the people following their stroke, we can see that they're below the first percentile. And again, if we think about exercise as medicine or improving their overall fitness, and again, if we think about exercise for preventing early death, we need to, boost their fitness. And so again, the majority of the people were below this first percentile. And then unfortunately, we didn't have normative data here. And then we had an individual who was in her 20s, I believe she was in her late 20s. And again, for her age and gender, she was below right at the 10th percentile. So again, for a young individual, this was really below those normative data. So we'd want to try to improve those. So, I'm trying, because of Zoom, I want to break some time up and allow for maybe any questions or clarifications before I move on. And so we know that stroke for fitness is low across stroke recovery. More and more evidence is coming out that, this is something we need to try to improve. And really, when we think about how physically inactive people are following their stroke, and this looks at the acute phase, many people, Julie Bernhardt in Australia, myself have looked at acute rehab and know that they're very low, and then in the chronic phase. So I don't know if there's any questions in the chat box, Liz, that anybody might want to ask for clarifications at this point.
I don't see any so far.
Okay. All right, I will move forward. So, one of the things, there's been different studies that we've looked at over time, and a lot of times in Australia and Europe, some of the studies that have come out have been where individuals will go into the room of the individual post-stroke and check on them randomly across an 8-10 hour day and document what activities that they are doing, whether it's toileting, sitting in a chair, lying in bed, things like that. And so when we were trying to design a study in the acute stage, again, in this first 4 days, 5 days post-stroke, my team, I don't have that kind of capacity or bandwidth to have somebody sit in there and document activities. So we decided to go with actigraph. I also thought that maybe we'd capture more or less activity. I know when I was thinking about it for myself, I thought, well, if somebody was sitting in a chair watching me do my activities, I wouldn't quite know what I would do and what I do, the normal things I would want to do if I knew someone was watching me. So we decided to use accelerometers. Now, the downside of that is we don't really know what they're doing. If you look at at this graph, you just get counts or levels of activity based on the movement of the leg. And so what we found in this acute phase is that this mean time spent, almost 94% was spent completely sedentary, 5.1% was in light activity, and 0.7 was in moderate activity, and 0 was vigorous. And again, we understand that this is the acute phase and maybe not a lot of people are moving around or very comfortable with this. But we felt like it was really good information to have. When we built our new hospital tower here at KU Med Center, this manuscript that we published in the Journal of Neurologic Physical Therapy was used as a way to talk to the hospital teams about putting in more of the overhead tracks, and also to use the vest to try to get people out of bed more. The tracks also go into the bathroom so that they can work with a therapist, or if there's a balance issue, that nursing can get them up and maybe they could walk to the bathroom. So we were very excited that this manuscript had some impact on how we treat our stroke patients. And again, if we compare this to healthy older adults, during the day, people tend to be a little bit more sedentary, and 21% were in light activity. And then when we look at and again, we know that they've had a stroke and there's a lot of variability in the 6-minute walk test during this acute phase, but we know that their walking ability is impaired, both their endurance, motor function. But, our goal should be try to get them up to where our healthy older adults are and be able to walk longer distances. So again, we know that activity is low in rehab and it declines further in the first year post-stroke. The study by Darcy Reisman's team I found was very interesting. And they found that they compared them to older, so these individuals were community ambulators. So they were all living at home in her study. And then the older adults were also living, was the control group that they compared them to. And both got up similar amounts during their day. It's just that the healthy older adults moved around for longer periods of time. And again, so if we're giving a message to, if somebody doesn't want to exercise, really staying up and moving around their house can also be very beneficial. So the FIT principle, when we think about this, like how often do we tell our patients to take their exercise medicine? How much do we prescribe? How many times per day? And again, some people are in favor of this approach and some are not. But again, I think it helps us frame this. The FIT principle is frequency, intensity, time, and type. And again, we're looking at this similar to medication. And I think these are important things to think about. And it's important for us to think about this and also give the message to our patients, because so often a lot of people, when we ask them, how active are you, or why don't you do activity, they just always say, I'm just not sure how much I should do after my stroke, or what kind of devices are safe, or what my heart rate range is. And so there's a lot of apprehension within people post-stroke about what they should or shouldn't do. So I was very privileged to be able to actually lead the statement on physical activity and exercise recommendations for people post-stroke. And it was very important to me to bring on a very interdisciplinary team. So we had people from OT, we had physicians, we had physiatrists, we had physical therapists and physiotherapists from Canada and Australia. We had people from Europe. We had, like I said, physician, nursing, and early career. So it was important for me to have this really passionate team about exercise and to be able to help me write these recommendations for people after stroke. The really hard part of this is that we still don't have concrete evidence for exercise dose. And a lot of times we say, well, why would exercise for people after stroke be any different than for their older adults or anybody at their age matched peers? And so again, it is recommended that they reach those general targets of 150 minutes a week of moderate intensity exercise. They should move on most days and try to avoid sedentary behavior. And then also, or 75 minutes of moderate or vigorous intensity exercise. But again, for stroke recovery, we really don't know whether there's an optimal dose, whether there's an optimal frequency or time that people should be exercising to improve their overall health. And so I've been thinking about that a lot for my future grants and trying to figure out how we can answer this question. So I consistently get questions about, and there's a lot of debate over, do I exercise test or do I not? What are the recommendations? What happens if I prescribe exercise and I don't have an exercise test? And I think this is it actually is a really good question that I get. And really what we say in our guidelines is that it's recommended before exercise, specifically of that vigorous intensity, because again, we don't know, if somebody has ischemic heart disease, what happens if they go out and they do high intensity interval training and, maybe there's some underlying ischemia. Again, there's a lot of people using, and I was just on a seminar with the Shirley Ryan Ability Lab, and they use high intensity locomotor training. And to me, that's a little bit different than the high intensity interval exercise where you're really trying to meet a threshold for heart rate. A lot of it, and I'll talk about the HIT trial that we're doing right now with the University of Delaware and the University of Cincinnati. But what we find is that a lot of people are limited by their locomotor function. And while they're doing fast locomotor walking, their heart rates may not be reaching those really high thresholds that we see, younger people or people who are willing to push their heart rates into that level. So I know that there's a lot of groups in inpatient rehab that are using high intensity locomotor and they're really doing that fast walking. But maybe their heart rates, again, depending on the bouts, that might not reach those ranges. We certainly don't want exercise testing to be a barrier for exercise. So again, if they're doing moderate intensity, such as brisk walking, maybe playing with their grandkids at the park, things like that, an exercise test is not needed. Again, being sedentary probably puts them at more risk than saying, don't do this, we need to have an exercise test. That's not the message that we want to send. For those who may not be familiar, I was also on this aerobics work group that it comes out of Canada. And I really love this. And I put this link here. This is very clinically relevant. There are questions related to clinical practice that I think are both meaningful for physicians, occupational therapy, for patients, for physical therapy. And it's set up very different than the recommendations that we use. This is really focused on clinical practice and how to integrate into practice. So if you're interested in this, you can Google aerobics, and it's at the Stroke Engine Canada, and then put in Marilyn McKay Lyons, and you should be able to find it on their website. If not, you're welcome to take a picture of the page and look up that link that way. For submaximal exercise testing, I would like to see more of this happening in the inpatient rehabilitation units and certainly in outpatient. I've seen a much greater increase in exercise testing for submax. Specifically, people are contacting me post-stroke, but I've also had a lot of interest in traumatic brain injury, spinal cord injury, amputation, and mostly of this is the recumbent stepper that I'll talk about. But submax exercise testing can be done on a treadmill, it can be on a cycle. And I don't have a lot of time today to spend on the recumbent stepper, so I'm just going to talk very briefly on it. I do a lot of CEUs on the recumbent stepper and teaching people how to use it and incorporate it using case studies and things like this. You can watch we have a YouTube video on how to do it. You can also find all the paperwork. We make it free. You can use all the paperwork that we have available for the exercise test that you could use because we want people to use it. But very briefly, because I started a long time ago in the late 90s, trying to prescribe exercise for people post-stroke, and really getting their heart rates into these zones was very difficult using a treadmill and a cycle. So I started working with the recumbent stepper. It's also called New Step, but you could use any recumbent stepper. I just choose to use that. I will also disclose I have no relationship with the company. I don't work for them, receive any funding from them. It's just a device that I have found that works really well for people after stroke and thinking about their disabilities and all the adaptive equipment that they have. And maybe Liz will chime in later when we take a break for questions, but I know that there are locations across the city that have access to recumbent steppers and other exercise equipment. We took an established YMCA protocol. This is made for a cycle ergometer, and it's already very established in the literature. And one of the things that I really like about it is it's based on physiology. So you're looking at, after this first stage, what their heart rate range is at that time, and then you're going to proceed in one of these tracks based on their heart rate. And certainly in inpatient rehab where we've done studies, a lot of times we're in this range. But again, unfortunately, I just don't have the time to really get into the exercise test. But if anybody wants me to do this down the road or where we get to travel, I've certainly gone to different places and done on-site CEUs where we've practiced recumbent stepping. I've done it in Singapore, Hong Kong, and all over the world. So it's been kind of fun to share this aspect of my research. So just, some people may be questioning the reliability of this. We've looked at it in healthy adults, very reliable. We did this, and this has been published in PLOS One. Dave Wilson was the lead author on this in 2017. It should be freely accessible. We also did this in stroke patients during the inpatient rehabilitation stay. Again, it was a small sample, but what we found is that, we did it after their therapy hour. So we always did it around after 4 p.m. I didn't think we'd have this strong of a correlation because we know in inpatient rehab, their days are busy. Sometimes they don't sleep well. But we were surprised again, how well the exercise test, was related on day 1 and day 2 of the exercise test. There's a group of us that if you are on this lecture and you are going to be attending the APTA Combined Sections meeting for 2021, there's a group of us. We did an exercise testing session, a 2-hour session in the cardiopulmonary section. We were asked to try to put together a seminar. Unfortunately, it's going to be all online. If you're a PT, you know this. But I think they should start advertising soon, but it's going to be a Precon. So hopefully, again, you'll be able to get more information if you're interested in the exercise testing. We do know that, again, I talked about this, that individuals, this is from the American Heart Association, they should try to reach 150 minutes of moderate aerobic activity or 75 minutes. And again, these are just recommendations for adults, which we use in our guidelines or in our recommendations. Strengthening, intensity is important. And again, the idea that sitting less and getting up and moving throughout the day. If we were live, I'd be asking people, it's okay to stand if you need to, but since we're all on Zoom, you can be doing, squats and I wouldn't know. For exercise prescription, again, I've gone through this. This is what we have, but intensity is really that important piece. And And when we look at the literature, and I'm going to talk about this in a study here soon, but it's really intensity that drives the vascular health. We've talked about high intensity interval training. I know that this is kind of the new, I don't know if I would say the new rage, but I know people are very interested in interval training. In healthy adults, it's been shown that you get higher VO2 max values when they do the high intensity interval training, and people like it because it takes less training time. I've always told people I'm a slow to adapt on the hit. I'm a slogger jogger. I like my moderate intensity, but I've started incorporating it a little bit, and I found that I'm starting to find my groove for my high intensity, and I like it. So again, we have to find what people like if they're going to do it. And when I do more of the exercise CEU courses, it's very important for us as healthcare professionals to ask our patients, our clients, what do you like? Because not all of them will do exercise, but can we get them to move more? And again, with people with heart disease, there's been some research that has come out that's showing that, again, they get greater improvement with VO2 max in less time. But we do have some questions in people post-stroke. And so I just wanted to highlight this, and then we'll take a little break and I'll see if anyone has any questions. But University of Cincinnati is actually the prime site. So Pierce Boyne is the leading physical therapist on this trial. Darcy Reisman is the primary site PI at Delaware, and I am at KU Med Center. And so what we're really interested in is doing their 30-second bouts of HIIT, followed by reduced intensity. And we're trying to find out what is the optimal locomotor training intensity for walking capacity. So do people improve with moderate intensity versus HIIT? And then what's the duration that makes that where we see improvements? Maybe we just need 4 weeks of HIIT. Do we need 8 or 12? And so again, these are just questions that we really don't know in this. And so this is a phase 2 trial.
Yes, that would go.
So in this 12-week study, these are our outcome measures. The primary is somebody might want to mute their computer. We're getting some background noise. Thank you. Is the 6-minute walk test. We're also looking at aerobic fitness, and then the 10-meter walk test. So again, very physical therapy focused as far as the gait training. So this is what it looks like, and I'm just going to go through this really quick. They're going to come in and do those sessions. We know that exercise is very beneficial. There's been a lot of literature that shows that we can improve VO2 peak doing exercise. There's been some small trials, and I know some more are starting to come out of, I feel like New Zealand and Australia are looking at cognition. I know there's a group in Europe and Canada that are also starting to focus on this. And the American Heart Association is very much interested in, heart health for brain health, and whether, we can improve cognition in people post-stroke. We know there's a lot more literature than what I've listed here for walking endurance, and this is typically measured as the 6-minute walk test. One study showed improved cardiovascular risk factors, and then I'm going to talk shortly about some vascular health in this study that was published in 2019. But if there are some questions in the chat box, Liz, I'd like to go ahead and maybe take those now if people have them.
There aren't questions in the chat box, but I have a question.
Yes.
You've talked about moderate, of course, I'm not a healthcare professional, so you talked about moderate and vigorous exercise. How do you explain the difference, or what's the difference between moderate and vigorous? When does it go from one to the other? And have you found a better way to explain that to patients so they know the difference?
Yeah. So usually what I tell people, if you're looking at moving around or this low intensity exercise, which is 40 to 50% of their heart rate max, 45 to 55 of heart rate reserve. I tell them that it's like walking to the refrigerator, walking to get your mail, maybe being in the grocery store. And again, this is assuming people have community, ambulation, just to be able to walk around would be what we would consider low intensity. Now, if you're short of breath, Like if you're walking around and you find, and so, when I do the next session for the community, I talk about the talk test. So again, low intensity, I think of that you can do the activity and you could talk and sing. You could hold a tune. During moderate intensity, I tell people you can still talk to somebody, and I think of this as brisk walking, where you feel like you're short of breath, but you could hold a conversation. But singing would be really hard. And then vigorous is, again, you're moving at a pace where you can't talk and you can't really sing. And that's the message I give for the community. For healthcare professionals, I always think of that high intensity, again, when we think about it just as heart rate, of that, if you take your heart rate 220 minus your age, and again, there's been debate on whether that's the ideal heart rate equation, but it's the most used. And you times that number that you get, so 220 minus your age, take that number and then multiply it by 0.85. Above that is what we call, that's vigorous and what I would call high intensity exercise. And then there's this range where you're probably at, maybe 55% of your heart rate max to about 80 or below that 85. And again, you have to kind of play around to see how you feel with it. But that's kind of a guideline. Between that range is a big range for moderate intensity. Does that answer your question?
I had to unmute. Yes, it does. And we do have other questions, but I'm going to let you finish your third piece here and then bring those questions in, if that's okay.
Sure. Or we can take them now if they're specific to the exercise or exercise testing.
Well, one had to do with a modified adapted HIT program, what that would include. And then another was, are there studies using RPE as a reliable measure of intensity during exercise in patients who are post-stroke?
Yeah, I think that I don't know if there's been studies specifically in the stroke population. I do know that in cardiac rehab, RPE is used a lot. And so we mimic that a little bit post-stroke and thinking about, and again, I do it in the community talk, I show the RPE scale. And so again, there are, I always tell people, the range that I like to see people get to for our patients is anywhere, if you're using the RPE scale 6 to 20, anywhere from 12 to 16 is a really nice range for our patients to be in. And again, you're going to have to ask them. So if they're on beta blockers or some medication and you're going to use the RPE, you still need to have a conversation. If they, if they're really huffing and puffing, and so sometimes we'll see that people say, oh yeah, I'm at a 12, and it doesn't look like they're at a 12. And so again, asking them, and you might have to say, clarify those things. Sometimes people will, they feel like they're barely exercising and they're at a 14 or 15. But again, that's their perception, and understanding that they may feel really tired about, at that exercise intensity. So that's a really good range. And then if you're at 17, 18, and 19, we really, a lot of times want to keep them below those ranges. Again, unless you're trying to get them into that vigorous intensity. So to answer the question about, is there evidence for RPE in stroke? I don't know that we have enough to do that. I have been involved in some work and doing exercise testing in people with early dementia, where the RPE scale was still very relevant. Compared to their age-matched peers, when we did some testing and exercise, they were able to, we were able to explain it, and they were able to use that during that time. Again, some of our people post-stroke might have aphasia, and the RPE scale may not be appropriate. They might have some, executive dysfunction where maybe, cognitively they're not able to, so then it wouldn't be appropriate.
One more question, Sandy, about one person said she loves the new step at the gym, but sometimes people have a hard time getting to the gym. Do you think the moderately priced recumbent steppers like Amazon's that are approximately $600, are they as effective as the higher end new step?
I think that's a great question. And I feel that if somebody's willing to purchase that, and it may be not as fancy, but they're going to do it, that's the best exercise. And anything that somebody's willing to do is still better than nothing at all. And again, that means just sitting less, moving more. So if somebody wants to buy one, again, and they're going to use it for movement, maybe they don't always reach those ranges we want them to be in, but they're doing activity and getting their heart rate up from sedentary. Absolutely, I would recommend that they do it. I think the question would be, if somebody has a disability, hip weakness, where they have don't have good control of the, of the leg, and are they exercising appropriately? Does it have adaptive equipment? With the new step, I always have to consider shoulder subluxation, because if anyone wraps their hand onto those bars and those recumbent steppers and it's moving, and I apologize that there's really no good way to do this to demonstrate, but we don't want that shoulder being pulled back and forth. So again, having conversations with your patients before they buy those things, and to be thoughtful about that to reduce injuries is important. But again, I think these conversations about health, and we've been working a lot with the APTA and trying to get these annual PT visits, or having patients come back to us just for quick checks if they are having issues for their health and exercise prescriptions. So we keep working towards that, and hopefully we'll get there someday. Any others, Liz?
Not right now. There's
Okay.
one. Okay, thanks.
I'm going to go ahead and move on just so we can keep going. So again, this is an overall summary. The optimal dose, we don't know. I think I stopped a little earlier. And again, we don't know the optimal dose for stroke recovery specifically when we think about neuroplasticity or what happens. How do we best facilitate that? And for secondary stroke prevention is still unknown. But what we do know is that exercise is very beneficial for our patients. There's certainly an interest in HIIT for walking and cardiovascular health, but again, we still don't know those optimal prescriptions for that. So very quickly, again, my lab did, until recently when we did the HIIT stroke trial, I did not have body weight support treadmill options. And so I use very much the recumbent steppers that you see here. And so we did a pilot where we enrolled 10 people post-stroke. We did an 8-week intervention. I was very deliberate on setting parameters for safety, for blood pressure. Again, you can see here, the RPE was between 12 and 16. We monitored them. We started them out at what we would call in the, the lower end of that moderate intensity. And then this is heart rate reserve. So we take into account their resting heart rate. And again, when I do longer exercise talks, I talk about the differences between age predicted heart rate max and heart rate reserve, but due to time, I don't have that ability today. In the second 4 weeks, we bump this up. Outcome measures, I won't present the 1-month follow-up today just for time, but we did pre and post intervention. We did a functional outcome 6-minute walk test, and then we looked at various measures of cardiorespiratory fitness. And then I'm going to talk about vascular health and using flow-mediated dilation. And so very briefly, if I put an ultrasound on your brachial artery and measure this, here's your blood flow at rest. We inflate a cuff. And so on your forearm, so we put a cuff right about before the elbow here, and we inflate that and we hold that for 5 minutes. And so when we release the cuff, you do get this big increase in blood flow, and then blood flow comes down. But what we see, and right here, you can see this is the brachial artery, and we're measuring the diameter, that due to that shear stress on the vascular wall, the diameter actually increases. So the percent change from rest to the peak is considered the flow-mediated dilation, or the percent FMD, or the percent change. And this is a measure of cardiovascular health. And the reason they say cardiovascular is that there have been studies both in humans and animals that the brachial artery most closely mimics the coronary artery. So if people have good vascular health in their brachial artery, it's assumed to say that this is similar to the coronary artery, and it's probably not exact, but similar. So one of the important outcomes, again, when we look at pre and post, so we lost somebody because they felt so great midway through our study that they went back to work. And so while that was great for them, we missed them in our analysis. But I will tell you that below 5% is considered a risk for cardiovascular disease. Most healthy people are between 8 and 12%. So you can see that the individuals post-stroke are below these normative data. And I don't have time to get into like the sided differences. And this is something I've seen in my research for years, both in the leg and the arm. But we see that the percent change after the intervention is about similar. So this tells me that people post-stroke can improve their vascular health. But we got them out of that just over that 5% range for some people. And this was statistically significant, both for the affected and non-affected brachial arteries. We didn't see any changes in heart rate at their resting values. They weren't statistically significant, but we did see that their resting blood pressure did drop. And this is really important. We tracked medications. There were no changes in blood pressure medications, any medications that affected blood pressure. Again, we enrolled these people no later than 4 months post-stroke. So it was very early in the stroke recovery phase. And we saw, again, a statistically significant and clinically meaningful change in their systolic blood pressure. Now, the 6-minute walk test was not clinically meaningful because we didn't quite reach 50 meters, but it was statistically significant. Again, this is very limited by our sample size. But I do want to talk just briefly about their VO2 peak. So I had really hoped that we'd see this get above 20 in our intervention. We didn't, but it was statistically significant. Heart rate didn't change much, and I didn't expect that to. And I don't have time to go into the respiratory exchange ratio, but this is a marker of physiologic, it's a physiologic measurement. So it's calculated respiratory exchange ratio by the volume of carbon dioxide consumed, expired, divided by the volume of oxygen consumed. And because these numbers were the same for these individuals, we can say that the improvement in VO2 peak was likely due to the exercise intervention. And this is hard to get these numbers up there in people post-stroke. So I always like the recumbent stepper because, again, I don't have to worry about balance. But what was interesting to me, when they're at their peak effort or they're working the hardest, they reported it as lower, even though they were working harder. And so for me as a physical therapist, this tells me that they can actually do more work, do more activity at that submaximal level, at that lower intensity, at that moderate intensity, and be able to do more during their day. So for me, that's a very important outcome that sometimes we don't think about from an exercise physiology perspective, but clinically for me, that was my take-home message. So in summary, again, I realize this is very short, but just due to time, exercise benefits vascular health. It's really that sheer stress, or when we increase our heart rate and our blood flow, that benefits the arteries. Exercise has vasoactive properties and has been known for blood pressure reduction. I'm just going to check at time here. So I'm going to keep moving. I had thought about taking a break, but I'm going to keep moving because I'd really like to talk about some very exciting work that we're doing, heart health for brain health. And so this paper came out from the American Heart Association from Phil Gorlick and colleagues. I wasn't on this when I say colleagues, but I know many of them. And so they were trying to define optimal brain health in adults. And I think that, again, this applies for any adult, whether they have spinal cord injury, stroke. And again, what they found in the literature is that really the American Heart Association Life Simple 7, which is be physically active, watch your cholesterol, look at your blood pressure, watch your blood sugars, all of the things that we do for cholesterol, all those things that we do that are good for our heart are actually good for our brain. And I work a lot with our KU Alzheimer's Disease Center, and we do a lot with lifestyle intervention. And so again, this is a message that I hear the neurologists sharing, which makes me very excited that people are thinking about heart health for brain health in our neuro populations. So one of the things that we've done has modeled we were the first in the world to really to do this. and I'll show how we do it, but we use transcranial Doppler ultrasound. But one of the things that we did is that we modeled this dynamic response continuously from rest to exercise. Now, it's been done where people use transcranial Doppler ultrasound a lot for people at rest, and it's also been done during exercise, but we did this unique modeling, which I'd like to show you here. But the reason I was very interested in this is, again, as a physical therapist, there's a lot of information I can get when I challenge the system, whether it's balance, it's exercise, blood pressure. You know, we want to challenge the system through exercise. So why should the brain be any different? So here's our setup in my lab. Sarah's wearing, and nobody's really that happy when they're all hooked up to this, but she was smiling for the camera. But again, the transcranial Doppler ultrasound is measuring the MCAV, the middle cerebral artery velocity that's going through here. So we can get, with each heartbeat, we get these waveforms. We monitor their heart rate with EKG. We also use this device, which is on their finger, to get beat to beat blood pressure. So you can't see it on the screen very well, but with each middle cerebral artery blood velocity, or the MCAV, with each waveform, we also get a pressure waveform. So we can look at that relationship between pressure and MCAV. We also monitor CO2. So we're getting the amount of CO2 that is being breathed out, because again, CO2 really affects blood velocity and brain blood flow. So using this equipment, we typically do a familiarization so they get used to the equipment. We target their workload. We look at it to see how we're going to reach their target heart rate. We have them rest for 20 minutes just to make sure everything's stable. And then here's our moderate exercise prescription. Again, we use heart rate reserve. This is considered moderate intensity in the range according to ACSM. We record for 90 seconds of baseline, then we do the exercise bout, and that'll make sense here shortly. And then we do this for 6 minutes. So our very first manuscript was in the Journal of Applied Physiology, and it was just a methods paper. And so we use this equation, and I'm not really going to go over everything today, but what you'll see is this resting MCAV is what we call baseline. We get, what do the individuals look like at rest? And then we go through, here's exercise onset. And the amplitude, or this amp, would be the peak, which would probably be right about here. And then the time delay is how much time after exercise onset when this starts to go up in an exponential way. And so again, I'm not going to highlight all of those, but this is a healthy young adult. This is a sedentary older adult, and this was somebody with a middle cerebral artery stroke who we age and sex matched to this individual. And again, this is only one person because this was a methods paper. We also wanted to characterize low intensity and moderate intensity. And I think this is so important for us to maybe not grasp all of the methods, but this low intensity is just, we prescribed it the same as everyday walking, like what we do to go to our office, walking around the grocery store, walking around our house. So if this is their baseline data, again, the low intensity is still higher than doing nothing. So if we think about exercise for brain health, this is great when we think about that low intensity exercise. And in the closed dark dots, again, this is the moderate intensity exercise right here. And this is in 67 people aged 20 to 80. So again, we have a large range. This isn't just healthy young adults, it's older adults as well. So again, the message for exercise for brain health, I think, is really important. And this is what we call CVR. We take a steady state average during 3 to 6 minutes. So for people post-stroke, again, exercise for brain health is understudied. There's a lot of interest in high-intensity locomotor training. My interest is really geared at the cerebral vascular response. So when we have a lot of these up-downs with exercise intensity, that's a lot of rapid fluctuations in blood pressure. And I would like to know, in people that have a stroke, what does that look like for people? So we did this in people post-stroke at 3 and 6 months. We hypothesized that over time, that their MCAV response would be greatest at 6 months post-stroke. And we based that off of some data in fitness showing that as you get out from recovery and you kind of get settled in, people's fitness, just doing more activity, goes up a little bit. And so we thought, well, if fitness goes up, because we know physical activity is important for brain health, heart health, that we thought that maybe 6 months would have the greatest outcome, and that people who were physically active would be related to this MCAV response. So here's our inclusion and exclusion criteria. Again, we had them have a unilateral ischemic stroke. We took a wide age range. We had a radiologist read the MRA or the ultrasound that was in the medical record for them on whether or not they had stenosis, because that would change our data. They had to be able to use the recumbent stepper. They needed to be able to walk because we were doing a 6-minute walk test, but I won't report on any of that data today. So if you're interested in stroke recruitment, if you're doing research, if you're a physician, we have a paper that right now is open access. It was just accepted in the Journal of Neurologic Physical Therapy, but we talk about how we leverage it's titled on physician engagement and how we leverage our physicians by either the team huddle in the acute stroke unit or the pathway that we use from the hospital admission and inpatient, and how we communicate, and then how they come to our lab, because we recruited them while they were in the hospital, and for them to come at 3 months post-stroke. So if you're interested in stroke recruitment and how we do our team science, that paper is available for you. So again, we followed the same things related to what I showed earlier. The sonographer was blinded to site of stroke. So we had them all set up except for the TCD so that they would not know which side was their stroke affected side, and so that to reduce bias. So unfortunately, we found no significant differences for outcomes at 3 or 6 months for our brain blood flow response, and that there was no differences between gender or race. But what we did find when we looked at age, so we split them into people who responded, where we had this exponential response, and those who didn't respond in a normal way. So it just meant that we couldn't model them because their brain blood flow response did not go up. So while these individuals are a little bit older post-stroke, it was not statistically significant. I would assume if we had more people in these groups that it would be, and that that age is actually maybe a factor in this blood flow response. No difference in gender, no difference in race. Unfortunately, we had no Hispanic or Latino. And then the time post-stroke between them was not different. But what we did find is that their estimated fitness was different, and the amount of physical activity engagement that they had was statistically different. There wasn't any difference in walk test, MRS, or their MOCA. So what we found was, and this was just fascinating to me when we graphed this. So again, these people are who we classified as responders in the filled in. Either the circles was their non-stroke affected vessel, and then the responders were the stroke affected vessel. And so you can see here in their non-stroke affected, and we took all strokes, that again, it increased rather nicely from their baseline, and same for the stroke affected. But you can see in the people who were non-responders, at baseline, they went up very early with the onset of exercise, but then it came down, and instead of going up and staying up, it actually came down in steady state. And so we're not really sure. We see a lot of these waves. This is not noise in our data. This is actually, we're going to look at the blood pressure waveforms, because we think that the middle cerebral artery velocity is actually following each blood pressure waveform, which it really shouldn't. It should be more smooth, like what you see here. So we're digging into this data a little bit deeper. It's currently, we're getting ready to do our second round of revisions for the Journal of the American Heart Association. During this time we had, and I know I don't have much time, so I'm going to try to hurry through this, but we had this gentleman who was admitted with MCA stroke on one side on the left, and then he had actually almost a year later had a right MCA stroke. So we asked our IRB, could we consent him again? and have him come in so that we could actually look at this opportunity to really see how a stroke might affect their MCA response to activity. And I'd just like to say that this individual, when he came in at 3 months post-stroke, was very active and was returning to cycling. So I just want to highlight this. So here's his baseline. So between the right and the left, and again, the left on this visit is the stroke affected side. So you can see that between the right and between the left and the right, that there's a difference right after this individual stroke, both at baseline and for the amplitude, so quite a bit lower. When he came back in at his second visit at 6 months post-stroke, both sides decreased, and we see that, and this is like from 3 to 6 months, both sides decreased. And then when he had his second stroke, look at the difference here. And this is very, very interesting. So again, we see that there's this drop in this MCAV. And again, during this time, he was very, very sedentary when he came in, watching TV, occasionally walking around the house and playing with his dog. So the activity changed quite a bit. And unfortunately, we didn't do Fugl-Meyer scores to really look at lower extremity function to see how limited he was by motor function. But we do have 6-minute walk test data. But again, you can see this change. And this was led by my MD Ph.D. student, Carolyn Kaufman. And this is published data in Physiologic Reports as a case study if you're interested. So again, future directions in stroke, I think we have to really understand the low, moderate, and high, continuous versus interval for vascular health and brain health. Long-term effects of exercise on the brain are important. We need, as a physical therapist, a healthcare professional, and just somebody who's interested in exercise, I feel like we really need to think about how exercise, brain health, and neuroplasticity, motor function all intersect, and how we can improve that in people post-stroke. And looking at mechanisms to really improve brain health is really important, especially for stroke, secondary stroke, but also really important. What we're seeing a lot more of is the increase in vascular dementia. Again, just summarizing, I think as healthcare providers, we need to talk with our patients. Exercise is definitely powerful medicine. We need more evidence in this, especially for brain health. And then this dynamic challenge that we're doing, we hope that it might reveal unique insights into cerebral vascular regulation and how we can think about exercise. So I'd like to thank Elizabeth Faustin for the invitation and putting on this wonderful conference for everybody. And it's just unfortunate that we're not in person, face-to-face, to be able to interact, but maybe someday I can come visit. I've definitely collaborated with the Alzheimer's team in Louisville. We had put in some U19 grants that unfortunately didn't get funded, but maybe there'll be a time for us to connect down the road. Certainly my collaborators and my lab team here is just a tremendous group of people, both DPT students, graduate students, and my staff, and then funding agencies. So with that, I'll take any questions that you might have at this time.
Thanks, Sandy. I'm going to give people a second to see if there are any questions. There was one from the previous section about whether what a modified or adapted HIT program might include. You may or may not know.
Oh, a modified, HIT. I thought you said HIP, H-I-P.
High intensity, yeah.
So I didn't answer that question. I'm sorry. Did you want to go back to your screen and I can stop sharing? That way you can easily transfer.
Sure.
Do you want me to do that?
You can stop sharing, yeah.
Okay. That way I can see also some questions that might show up in the chat as well, maybe. Yeah, so a modified HIT, for individuals with stroke, I don't know if the person that asked the question is thinking about, so one of the things I'm really interested in is like doing a moderate intensity HIT, just doing some type of that interval. Like, do people post-stroke really need high intensity? And so there's a study in older adults that came out in Medicine and Science and Sports and Exercise that looked at moderate intensity interval. And both of the intervals, of course, the HIT's going to induce in healthy older adults different things. But again, is it that interval exercise, that continuous up down that's valuable, and that increase in shear that might be a way to modify the interval to do, HIIT in a more of an interval manner versus that really high intensity training. I don't know what the modification means. Like if you're talking about instead of locomotor HIIT, doing like recumbent stepping HIIT. Pierce has published some work on that. Or if you're talking about like the different intervals, there's long interval HIIT, which I can't imagine how somebody post-stroke could do 4 minutes of high intensity interval, followed by 4 minutes of a lower intensity. I've tried it, and it's not easy. If you haven't tried 4 minutes of HIIT, before you prescribe that, try it. But there's, different bursts, like of 1 minute, and then there's bursts of 30 seconds. I personally am a fan of the 1 minute bursts followed by 1 minute at like 40 to 50% of heart rate. So having them come back down. I'm not sure if I'm answering the question.
Well, I think that the modified means that would be effective for someone who
With a
has
disability,
physical, different limitations, different, if your arms are affected, your legs are affected.
Yeah. So I think interval exercise can be done either with the legs only, which we're getting ready to start a study on the recumbent stepper where we're doing legs only for people post-stroke, and then looking at that, and also thinking about brain blood flow response during that. So I think you can modify it in that way. I mean, certainly if you're using a recumbent stepper or a bike, you can use HIIT. I haven't ever really seen anything for like FES HIIT. And maybe in the spinal cord injury literature, but that doesn't mean it's not out there. For stroke, certainly I could see doing a bike and using modified, a glove to help somebody keep their arm on, or, the new step specifically has the leg stabilizer that'll keep their leg in alignment so that it allows them to use their legs. But you can modify it in that way. Hopefully I answered that question.
Well, Sandy, I just want to thank you so much for this great information and your willingness to do this via Zoom. And, I appreciate your research and also just the urging us to continue on the topics that are under researched. In the interest, we do. Here's one last question, and then we've got to move on because we're crunched for time. It says, Sandy, I don't know if you can see that. That just dropped away. It just said, here, I can do it. It says, do you do 1 minute high intensity and then 1 minute rest and alternate that?
Yes, we do. Not stopping. I am not a fan of completely stopping, but you can go down. We're going to test the different lower intensity. So you could go down to 10% of heart rate reserve, or of like their overall wattage. I think going from the HIIT around the higher intensities to 30 to 40% of their heart rate would be good, just to keep blood flowing in the limbs and not have them be static would be my recommendation. I do like them 1 minute. Yeah.
Okay.
Well,
we're gonna move on and see if we can how far off track we're going to get with regard to time. I'm going to try to do a couple of things right now, folks. So I'm going to share my screen. I am.